Welcome. Aesthetics are procedures which attempt to reverse the effects of aging on our appearance. And facial appearance depend on the soft tissues draped over the underlying supporting tissue. The soft tissues include skin, subcutaneous and deeper fat, superficial and mimetic deeper muscles, and deep fascia. The supporting tissues include bone, cartilage, and teeth. Causes of aging changes include skin atrophy from loss of collagen and elastin, loss of subcutaneous fat, remodeling of bone which includes projection in the forehead and brow regions, and regression in the mid and lower face. Descent or sagging of soft tissues due to weakening of ligaments connecting the underlying bone with the skin and the underlying fascia with the skin. Relative overaction of mimetic muscles producing wrinkles or rhytides, such as the corrugated supercilii and the procerus, which are the depressors and rotators of the medial eyebrow, producing vertical forehead rhytides. Frontalis, which is the elevator of forehead, brow, and eyelids, producing horizontal forehead rhytides. Orbicularis oculi, which cause eye closure, producing lateral canthal and lower eyelid rhytides. When evaluating for effects of aging, the entire face needs to be evaluated to avoid unbalanced rejuvenation. For example, appearance of the upper eyelid is closely dependent on the position of the brow, and lower eyelid appearance depends on the status of the soft tissues of the midface and chin. The aging changes in the face include rhytides in the forehead, both vertical and horizontal, rhytides in the lateral canthal area, and rhytides in the perioral area. Loss of fullness of the forehead between the frontal eminence and the eyebrow, and loss of fullness of the temple. Descent of the eyebrow, the lateral portion more than the medial portion, called lateral hooding. Thinning and stretching of skin, and we have this Fitzpatrick skin type based on skin pigmentation before and after sun exposure. This typing is important before procedures such as chemical peeling and laser skin resurfacing. Periocular aging changes include skin fold above the upper eyelid crease, which is convex when the globe is relatively large compared to the orbit and is concave when the globe is relatively small compared to the orbit. A sunken appearance of the globe from enlargement of the bony socket due to bone resorption. Prolapse of orbital fat pads, which is a very important contributing factor to periocular aging changes, and this occurs from atrophy of the orbital septum and the skin orbicularis layer. Prolapse of the orbital lobe of the lacrimal gland. Changes in the positions of the upper and lower eyelid margins, upper eyelid crease, lateral canthus, which is normally 1 to 2 millimeters above the level of the medial canthus, and horizontal lid laxity, especially that of the lower eyelid. Sagging of midface soft tissues, which include prominence of inferior orbital rim, which is also called skeletonization, prominence of inferior orbital fat with laxity of the overlying skin, also called festoon, and infraorbital hollow, also called tear trough, beneath the festoon. Sagging of platysma in the neck region resulting in skin sagging along the jawline, which is also called jowling. Nasal deformities and thinning of the lips should be looked for, and a side view of the face is very helpful to detect aging changes. A photographic documentation is absolutely essential before any aesthetic intervention. Facial rejuvenation procedures can be non-surgical or surgical, and in general, non-surgical procedures are meant to create involutional and actinic changes of the skin, and these can precede or accompany surgical procedures. Surgical methods in general are required to reposition deeper structures. Laser resurfacing procedures are most commonly used to reduce wrinkles, and ablative lasers are used which tighten collagen and shrink skin. Usually superpulsed carbon dioxide laser or erbium YAG laser are used, and superpulsing of carbon dioxide laser allows cooling between the pulses, minimizing thermal damage, whereas erbium YAG laser is almost purely ablative, causing even less thermal damage than carbon dioxide lasers. Appropriate patient selection for laser resurfacing is essential because application of laser on pigmented skin can lead to post-procedure inflammatory pigmentation. Laser resurfacing can be used along with blepharoplasty to avoid resection of skin, and we will be talking about blepharoplasty in this session. And contraindications to laser resurfacing include collagen vascular diseases and significant uncorrected lower eyelid laxity. Periocular complications of laser resurfacing include lagophthalmos of the upper eyelid and ectropion and retraction of the lower eyelid from excessive contraction of the skin. Laser resurfacing can also lead to recurrence of previous HSV infection, which may lead to skin scarring. Botox or botulinum toxin is the most commonly performed cosmetic procedure. It is obtained from Clostridium botulinum, and it is considered to be the gold standard treatment for dynamic wrinkles. Dynamic wrinkles are caused by contraction of mimetic muscles, and Botox treats dynamic wrinkles by paralyzing these mimetic muscles. And Botox can be used to treat dynamic wrinkles in the glabellar, forehead, lateral canthal, perioral and platysmal regions. Botox can also be used for brow lift and widening of the palpebral fissure. A central glabellar injection results in a compensatory lateral brow lift, which is considered to be aesthetically desirable. Repeated use over a long period has been shown to favorably improve biomechanical properties of the skin, and FDA has approved several varieties of botulinum toxin A, among which botulinum toxin A is the most commonly used. Dose and injection location should be individualized for each patient depending on response to previous botulinum toxin injection. Following Botox injection, onset of action is usually within 2 to 3 days. The peak effect occurs in 7 to 10 days, and the duration of effect usually lasts 3 to 4 months. Complications of Botox injection include ptosis, lagophthalmos, ectropion and entropion, and these are all due to paralysis of the respective muscles. Dermal fillers are used to treat volume loss and wrinkles, and they can be used to fill volume loss in temporal wasting, frontal hollowing, and hollowing in the supraorbital or infraorbital regions. They can also be used to fill deep static wrinkles which cannot be corrected by Botox. Hyaluronic acid is the most common dermal filler used, which is actually a natural constituent of the extracellular matrix of the skin, and it is obtained from Streptococcus equus. Hyaluronic acid attracts and retains water, providing immediate volume replacement, and in the long run, it also promotes collagen production by mechanical stretching of the tissue. Highly viscous preparations are used for deeper injections to give significant lift effect, but low viscosity preparations are preferred for superficial injections to avoid excessive tissue fill. Injection of hyaluronic acid as dermal filler is considered reversible because hyaluronic acid can be dispersed by injection of hyaluronidase. However, hyaluronic acid or other dermal fillers are not FDA approved for periocular use, and this is because inadvertent intraarterial injection can cause tissue necrosis and central retinal arterial occlusion. The skin necrosis is followed by scarring of the skin, and the necrosis usually occurs immediately following injection but may also be delayed. CRAO occurs because the terminal branches which supply the face are terminal branches of the ophthalmic artery, and intraarterial injection of these fillers can lead to retrograde flow reaching the main ophthalmic artery and then to the central retinal artery, leading to blindness, which is abrupt and often painful and occurs most commonly following glabular injections. When this occurs, immediate retrobulbar injection of large volumes of hyaluronidase may help. Autologous fat is also an alternative dermal filler and can be used in a similar manner with similar risks, but unlike hyaluronic acid, autologous fat can have variable growth and resorption following injection as a dermal filler. Topical application of Bimatoprost on eyelid margin improves the appearance of the eyelashes in length, fullness and color, and this is indicated for eyelash hypotrichosis. Here we see photographs showing changes in the eyelashes before and after application of Bimatoprost. Surgical techniques for facial rejuvenation include blepharoplasty, brow ptosis correction, mid-face elevation and lower face rejuvenation. Indications for upper and lower eyelid blepharoplasty is chiefly cosmetic, but there can also be functional indications for blepharoplasty. Functional indication for upper eyelid blepharoplasty can be obstruction of the superior visual field from excessive skin on the upper eyelid, and functional indication of lower eyelid blepharoplasty can be difficulty in reading, which occurs due to excessive lower orbital fat obstructing the near segment of a spectacle. Evaluation for both upper and lower eyelid blepharoplasty includes a complete routine ocular examination, assessment of the location and amount of excess skin, assessment of the amount and contour of prolapsed orbital fat. Removal of excess skin and prolapsed orbital fat are the chief aims of a blepharoplasty procedure. Detecting the presence of a lag ophthalmos, if any, and evaluation of the tear film for its abnormalities are important to prevent postoperative ocular surface complications, and a photographic documentation is essential as we have discussed earlier. In addition, evaluation for an upper eyelid blepharoplasty includes noting the positions of the forehead and brow with their muscles, chiefly the frontalis muscle, relaxed. If a brow lift is required for an associated brow ptosis, it should precede the upper eyelid blepharoplasty. This is because the brow lift preceding the upper eyelid blepharoplasty reduces the amount of upper eyelid skin which ultimately needs removal during the upper eyelid blepharoplasty, and also because an upper eyelid blepharoplasty without the preceding required brow lift will pull the eyebrow further inferiorly. A lacrimal gland prolapse, if present, should be noted, and visual field testing once with and once without elevating the upper eyelid is important for documentation. Additional evaluation for a lower eyelid blepharoplasty includes assessment for horizontal and canthal tendon laxity with snapback and distraction tests, which we have discussed in the session on ectropion, and a lid tightening procedure, if required for lid laxity, should precede the lower eyelid blepharoplasty procedure. Detecting relative exophthalmos and or hypoplasia of the malar prominence is important because if they are present following a lower eyelid blepharoplasty, there can be lower eyelid retraction and scleral show, and a mid-face lift procedure may be required to prevent them from happening. Primary aim of blepharoplasty is to remove excess skin and prolapsed orbital fat, as we have mentioned, and upper eyelid blepharoplasty starts by marking the excess skin which needs to be removed before administering infiltration anesthesia. The upper eyelid skin crease is marked from above the superior punctum to the lateral orbital rim, and if the upper eyelid skin crease is not present, the skin marking is done 8 to 10 millimeters above the upper eyelid margin. One arm of a grasping forceps is held along the crease mark, and the other arm of the grasping forceps is used to pinch upwards the skin immediately inferior to the crease mark, to the extent that the skin further below is tight without lag ophthalmos when the eye is in down gaze, and the level at which the second arm of the grasping forceps holds the skin marks the inferior skin incision. As a rule of thumb, after the skin excision, at least 20 mm vertical length of skin must remain between the inferior border of the eyebrow and the upper eyelid margin. And ideally, on opening the eye, the upper and the lower skin marks should coincide. The marked skin is then incised and removed, following which the globe is pressed posteriorly gently so as to make the prolapsed orbital fat push the orbital septum and the orbicularis muscle anteriorly. The orbicularis muscle and the orbital septum are then opened centrally, and the capsules of the prolapsing fat pads are then incised, and the excess bulging fat is then gently transected. Then the orbicularis is sutured to the LPS aponeurosis above the superior tarsal border. This creates the upper eyelid skin crease and also holds back remaining fat. Following this, the skin is closed. Lower eyelid blepharoplasty can be done either through a transconjunctival or a transcutaneous approach. A transconjunctival approach is employed when only removal of prolapsed fat pads is required and there is no need for removal of excess skin or horizontal lid tightening, and transconjunctival approach avoids external scar formation and lid margin distortion which may occur with a transcutaneous approach. However, a transcutaneous approach is required when horizontal lid tightening and excess skin removal is needed. The transcutaneous approach to lower eyelid blepharoplasty is similar to upper eyelid blepharoplasty. A horizontal skin orbicularis incision is made 3 mm below the lower eyelid margin from below the inferior punctum to lateral canthal angle. Gentle posterior pressure on the globe reveals the prolapsed fat pads. The orbital septum is incised and excess fat is gently transected, and the inferior oblique muscle separates the medial fat pad from the central fat pad, and while removing fat from the medial fat pad, the inferior oblique muscle should not be injured. What is most important is care must be taken to avoid postoperative hematoma by avoiding excess traction on fat pads when resecting prolapsed fat, making sure there is no active bleed when residual fat is allowed to retract posteriorly, and careful hemostasis. Horizontal lid tightening, if required, is done at this stage, followed by removal of excess skin as required. However, orbicularis is preserved. It must be noted that excessive removal of skin and fat in the lower eyelid may lead to retraction and ectropion of the lower eyelid or a sunken periocular appearance. Finally, the orbicularis and the skin is closed. In the transconjunctival approach to lower eyelid blepharoplasty, the lower eyelid is first everted. A conjunctival incision is made in the lateral portion of the conjunctiva 4 mm inferior to the inferior tarsal border. Excess fat in lateral fat pad is resected, and then the conjunctival incision is extended medially, and excess fat in medial and central fat pads are resected. The conjunctiva is then closed, and careful hemostasis needs to be maintained during fat removal as mentioned previously. The most dreaded complication of blepharoplasty is loss of vision. This is rare but can be permanent, and this occurs due to orbital hemorrhage. It usually occurs with lower eyelid blepharoplasty, and risk factors include hypertension, anticoagulant use, and blood dyscrasias. Measures which can be taken to reduce the risk of loss of vision from orbital hemorrhage following blepharoplasty include stopping antiplatelets and anticoagulants before surgery, controlling blood pressure pre-operatively, intraoperatively as well as post-operatively, very careful hemostasis, gentle handling of fat pads, avoiding pressure dressing at the end of surgery, and patients should be advised to avoid strenuous activity for 4 to 5 days following surgery. The patient should be under observation immediately post-operatively following blepharoplasty, and occurrence of pain, proptosis and or decline of vision should be treated immediately as orbital compartment syndrome. The blepharoplasty incisions are opened, a lateral cantholysis if required is done, and exploration of deep orbit may be required to identify the bleeder. Other complications following blepharoplasty include diplopia, which occurs due to injury to either inferior oblique, inferior rectus or superior oblique muscle during manipulation of orbital fat, and surgical correction of this diplopia is deferred for at least 6 months after blepharoplasty to allow adequate time for spontaneous resolution. Ptosis following blepharoplasty may be pre-existent, being masked by excess eyelid skin of dermatocalasis, or may occur post-blepharoplasty due to iatrogenic LPS damage. Here also, correction of the ptosis should be deferred for at least 6 months to allow adequate time for spontaneous resolution. Excess skin removal, as we have mentioned, can lead to lagophthalmos of the upper eyelid or eyelid retraction and ectropion of the upper as well as the lower eyelid. Mild cases of lagophthalmos and ectropion may be treated by topical lubricants and massage, whereas severe cases of lagophthalmos will need surgical closure of palpebral aperture, and severe cases of ectropion will need skin grafting with or without mid-face lift. Brow ptosis is defined as location of the eyebrow below the superior orbital rim. Normally the brow is located at or above the level of the superior orbital rim, and it is higher and more arched in females as compared to males. Brow ptosis is due to loss of elasticity and volume of forehead tissues and involutional skin changes. Brow ptosis can also occur with facial nerve palsy due to paralysis of the frontalis muscle, which lifts the eyebrow. Clinical features of brow ptosis include headache, brow ache, and horizontal forehead rhytides due to constant action of the frontalis muscle, a lower position of the eyebrow below the superior orbital rim, and loss of superior visual fields. Brow ptosis can be associated with dermatochalasis, and when brow ptosis and dermatochalasis occur together, as we have mentioned when discussing upper eyelid blepharoplasty, correction of brow ptosis should be done prior to or simultaneously with upper eyelid blepharoplasty. This is because prior brow elevation reduces the amount of upper eyelid skin redundancy and thus the amount of upper eyelid skin which ultimately needs removal. And also because aggressive blepharoplasty alone without the brow lift which is required leads to further lowering of the brow, particularly the lateral brow, leading to a sad appearance. Evaluation for brow ptosis includes determining the amount of brow ptosis with the forehead relaxed, noting the level of the hairline and the vertical height of the forehead to determine the surgical approach for forehead or brow lift as we will be discussing, and noting the presence of laxity of skin and rhytides to determine the need for surgical removal of extra skin. There are several techniques for correcting brow ptosis, and browpexy is indicated for a mild brow ptosis. This is done through an upper eyelid blepharoplasty incision through which subbrow subcutaneous tissues are sutured to the periosteum of the frontal bone above the superior orbital rim. However, this technique does not elevate the brows significantly but can prevent prolapse of retroorbicularis fat into the eyelid. Direct brow elevation is indicated in mild lateral brow ptosis, and the incisions are placed just above the brow. It provides for moderate brow elevation, but the brow elevation is less than in forehead lift, which we will be discussing next. However, the risk of hematoma and nerve damage is less in direct brow elevation compared to forehead lift. Endoscopic brow and forehead lift, also called forehead plasty, is indicated in patients with a low hairline, and in this technique small incisions are made 1 cm above the hairline. The periosteum is lifted in the forehead region up to the superior orbital rim. The dotted lines in this diagram shows the extent of periosteal elevation. The procerus and the corrugated supercilii should be weakened or excised if there are significant vertical rhytids, and the elevated periosteal flap is then refixated to the underlying bone, giving a forehead lift. Pretracheal brow and forehead lift, also called bicoronal forehead lift, is indicated in patients with a high hairline. In this technique, the incision is made below the hairline, and after dissection of the subcutaneous tissue, the galea, that is the periosteum of the skull bone, and the frontalis muscles are plicated. Excess forehead skin, if required, is resected, followed by skin closure. Pretracheal brow and forehead lift provides the maximum forehead lift among the various techniques of forehead and brow lift. However, the risk of hematoma and nerve damage is higher than the other techniques. Mid-frontal forehead lift is indicated in patients with deep horizontal forehead furrows and a high hairline. In this technique, the incision is made along a deep horizontal furrow, and the procerus and the corrugated supercilii can be approached directly through this incision in this technique. However, the forehead elevating effect in this technique is less than that in the bicoronal approach, but with a lesser risk of hematoma and nerve damage. Complications of brow or forehead lift procedure include scar formation, alopecia, injury to the branches of the facial nerve, hematoma formation causing necrosis of the overlying flap, overcorrection leading to an expression of perpetual surprise, or undercorrection. Midface should be assessed in any patient presenting for lower eyelid blepharoplasty, and sagging of midface tissues results in prominence of inferior orbital fat as well as prominence of the inferior orbital rim, which appears as a double convexity from side view. Midface elevation can be done through forehead endoscopic incisions or through superior gingival sulcus incision. The midface tissues are released from the underlying bone with or without conservative fat removal or fat repositioning, and the midface tissues are then again resuspended to the underlying bone. Ignoring the lower face during facial rejuvenation may lead to an unbalanced facial appearance. So a multidisciplinary approach may be required for complete facial rejuvenation. In rhytidectomy, the superficial muscular aponeurotic system is lifted posteriorly and laterally. A deeper lift has a longer lasting result with a higher risk of facial nerve injury as compared to a more superficial lift. Liposuction is removal of subcutaneous fat, and for this, liposuction cannulas are introduced through post-auricular or submental incisions. While removing the fat, a layer of subcutaneous fat is left along the dermis to prevent dermal scarring. In platysmoplasty for jowling, the lateral portion of the platysma is resuspended from the lateral neck and medial platysma is reconstructed. Thank you for listening.